Welcome back to pharmacology. In this block, we're going to focus on the array of adverse effects that are seen with drugs. And this overlays with issues related to allergy status. It also overlays organ function and overlays issues for example, a woman of childbearing age who may take medication as well. In this block, we're going to look at drug toxicity and adverse events. We'll focus on a few different areas. One, the nature of adverse reactions or negative consequences of drug use in general. And then we'll talk about some specific types of drug toxicities, drugs affecting bone marrow, drugs and their effects on liver or kidney function and toxicity. We'll also talk a bit about teratogenicity, which is a study of how drugs could adversely affect a developing fetus for a woman who gets exposed to the drugs during pregnancy. And we'll wrap up with allergic responses to drug therapy. Everything we do in pharmacology is related to this concept of risk versus benefit. And when we have a patient in front of us, we want to make sure that, first of all, we've assessed their condition, and if their condition is such that they could benefit from pharmacotherapy, then it's important for us to establish or quantify what we think that benefit is going to be for the patient who's in front of us. So as you're looking, for example, through medical literature, as you're evaluating drug monographs and looking at indications for drugs, you may, for example, have a patient with a condition with hypertension. Not all the antihypertensives you have available to you will have the same risk and benefit ratio for the patient in front of you. While first-line therapy, for example, for most patients with hypertension might be using an ACE inhibitor like lisinopril, we'll talk more about that drug later in the year, for a subset of patients, the risk for that therapy would be too high. Those include women who could be pregnant or of childbearing age because we know that this class of drugs, these ACE inhibitors, the angiotensin-converting enzyme inhibitors, are known to be teratogens, or drugs that pose a risk to a developing fetus. We would also be concerned about using a drug like this for someone who had a history of an allergic reaction to an ACE inhibitor. And the classic presentation of rare but very serious allergic reactions with ACE inhibitors is a condition called angioedema. We'll talk more about that later, both in this block and later in the year. So in a nutshell, for the patient who's in front of us, you weigh what are all the benefits associated with this drug. Are we going to achieve good blood pressure control? More importantly than that, are we going to achieve with this patient a reduced future risk for kidney disease, for heart attack, for stroke, for other consequences of uncontrolled hypertension? And can we do that in a way that poses the least amount of risk for this patient? Always evaluating that. So the rest of this block today talks about the risk side of the equation. There are a few definitions that are listed here. I will try not to spend too much time on them, but they're there for you to look at. One of those terms, side effects. Its side effects we'll define as a nearly unavoidable secondary effect of a drug that's seen in therapeutic doses. That definition varies, but classically what you'll see is that many medicines, for example, early in the course of therapy might have some sedation associated with them, and often, for whatever reason, that sedation is less prominent as the drug use continues. That'd be considered a side effect. A toxicity, classically in the term of toxicity, is an adverse drug reaction caused by excessive dosing. But in practice, we use the term drug toxicity to include a negative consequence to drug therapy, even if it is in the normal dosing range that we would expect to use. A drug overdose, we classically think of both a toxic presentation in conjunction with excessive dose, and that excessive dose may be excessive for the general population at large, or it might be just excessive for that patient because we didn't adjust that dose based on someone's renal or hepatic function or body weight or something else. Idiosyncratic effects refer to an uncommon, relatively uncommon drug response, usually resulting from a genetic predisposition. For example, Most folks for whom we give a benzodiazepine like lorazepam, Ativan, or diazepam, Valium, will exhibit some degree of sedation. There are two folks, though, groups of folks who might get more agitated. One of those folks might be older patients who are at risk for delirium with benzodiazepines, and the reason that they fall into delirium is that the benzodiazepine makes their visual and environmental cues a little less precise for them. They get a little more confused and then worried about that confusion, feeling like they don't recognize or know what day or time it is, or time of day it is, or the environment that they're located in. And so sometimes benzodiazepines can cause uncommon and an unexpected drug response. Other patients might just find that the benzodiazepine actually causes them to feel more anxious or agitated. That is in itself a true idiosyncratic type of reaction. It doesn't happen often, but we do see it. Iatrogenic disease refers to a disease that we caused. If you think about the classic oath that we take as healthcare providers, and one of those classic things that we'll always say is first do no harm. And we need to remember that, but we'll find that in practice we see that actually what we did, how we intervened, the environment we put that patient in contributed to their demise or a condition or a disease. So classic examples of iatrogenic diseases include drug-induced renal failure, drug-induced Clostridium difficile infection because we used broad-spectrum antibiotics in conjunction with a proton pump inhibitor in an environment in the hospital where C. diff spores were available. So iatrogenic is something we always want to avoid. The concept of physical dependence is a state in which the body adapts to prolonged use of the drug, and on stopping the drug acutely, the patient will exhibit an abstinence syndrome. That is classic, and we think of that, you'll think, okay, that's true for someone who is addicted to heroin. We will see that when they stop, when the heroin gets out of their system, they'll go through acute withdrawal. So that is an example of physical dependence. But you could also have physical dependence where there isn't so much the addiction quality of changing. Addiction has, and we'll talk about this later in the year, but addiction has a quality to it that people will continue to exhibit a certain behavior despite known risks or harms for engaging in that behavior. We could call physical dependence someone who's on long-term prednisone. When they're on long-term prednisone and then we stop their prednisone cold turkey, the problem is with long-term prednisone, our body acclimates to that prednisone that we take orally. We no longer produce cortisol. So if we were to stop prednisone for somebody who's been on prednisone for a long time, they actually will have a physical dependence kind of phenomenon to that, and a specific abstinence syndrome. We'll refer to that as Addisonian crisis on stopping it. Carcinogenic effects, we refer to carcinogenicity as the ability of medications and or environmental chemicals to produce or increase the risk for cancers. Most cancers, when they occur, are multifactorial in their origin. The drug usually itself alone can't cause or won't cause cancer, but the drug in combination with a genetic predisposition in a patient in a particular environment where there might have been other environmental influences, maybe a viral infection, maybe another chemical exposure, all of that combination leads to the increased risk for development of cancers or early cancers. So that's the term carcinogenic. Teratogenic is the ability of a drug to cause a birth defect in a developing fetus. We'll talk more about that in a little bit here. Some more definitions. Drug interaction is the action of a drug on the effectiveness or the toxicity of a second drug. That's classically a drug-drug interaction. Later in this block, later in the summer, we'll talk a little bit about drug-disease interactions and even drug-lab interactions to a little degree, how a drug can make a different disease worse or how a drug can make a lab test look false positive or false negative. But when folks talk about drug interactions, most often they're referring to drug-drug interactions. That interaction can also be a drug in a food, something else. It's basically when one drug interferes with the action or affects the action of another drug. Drug intolerance is the term we use to describe a low threshold for the normal physiologic pharmacologic action of a drug. We've all known patients for which a little bit of drug goes a long way for them. And so on the dose response curve that we talked about earlier on in this block, they're really on the left-hand side of that a little bit of drug goes a long way for them. And so we kind of see that their S-curve on that dose response curve shifts quite a bit to the left. Imagine picking up that graphic and moving it to a lower scale, and the very low doses actually for them produce dramatic effects. A drug allergy officially is an immunologically mediated reaction. It's characterized by its specificity. It's transferable by antibodies or lymphocytes. It recurs on re-exposure. It's an immunologically based reaction. In clinical practice, you will find that over the last 50 years, we have often used the term a patient is allergic to a medicine when truly they're not. It's not an immune basis. It's an intolerant. They're not able to tolerate. It's a drug intolerance, not an allergic-based reaction. And the reason that nomenclature sometimes gets cloudy is that at least historically in the medical record and even in the electronic medical record, the place where people would go document if they've had a problem with a drug or a food is in the allergy section. And so in the allergy section of the medical record, they will document when someone's had an intolerance or a true allergy. What's important, and most systems now and medical records account for this, requires you or asks you strongly to put in or to quantify and qualify what the patient's reaction was to that drug allergy or intolerance. And many electronic medical records go further and have you specify whether it's an allergy or just a drug intolerance. That's critical because if we label a patient truly allergic to a medicine, that could wipe out a whole class of medicines that are mainstay first-line therapies for us. The classic example are the penicillins. Penicillins are of a concern for us when folks have an allergy to them because about a quarter of the antibacterial agents that we're going to use in clinical practice, or a third of them, are somehow related to the penicillin molecule. If we've labeled someone, quote unquote, allergic to penicillin, then we've just wiped out a third of the agents we could use to treat that patient. Finally, we have pseudo-allergic reactions. These are reactions that aren't real allergic reactions, but they look like a real allergic reaction. The classic mechanism here is a drug, when it's given quickly, might cause a release of histamine in localized tissue that presents like a rash, almost like hives. The two drugs we see this happen very commonly with is morphine. We give morphine IV push quickly. Many patients will have almost a hives kind of reaction to that, and then they get labeled allergic to morphine. That's a problem because, in fact, if it were a true allergic reaction, which it almost always is not, then that would wipe out a whole load of opioids we could use for analgesic or pain management for that patient. The other drug where we see commonly seen with pseudo-allergic reactions is the antibiotic vancomycin. Vancomycin, if it's administered relatively quickly, over less than an hour, for example, patients may have an infusion type of reaction around their face and neck, and that syndrome has terminology of what it's called, and the two terms it's been adopted to use over the last 30 years will offend someone. One of them is called a red man syndrome. The other one is called a red neck syndrome, neither of which really are really the best of terms. Probably the appropriate term is just called a vancomycin flushing reaction. But people still utilize that terminology. In any event, the way we prevent that is give morphine more slowly or give vancomycin more slowly, and this histamine release reactions won't be as pronounced. All right, let's talk a bit about adverse drug reactions themselves. They're basically something bad that happens. It's not intended. It's a noxious medical occurrence that a patient experiences. The Food and Drug Administration, when they approve drugs, may approve drugs. Many drugs on the market get approved when there aren't that many patients who have experienced that drug. Some drugs are approved on the market with as few as 1,000 or 1,500 patients ever being exposed to the drug. So if the adverse event is a 1 in 10,000 but very serious life-threatening event, by the time the drug first hits the market, there may not have been enough patients treated with that in the early studies to have identified that as a problem. And so as clinicians, I encourage you, and what most seasoned clinicians do, is be quite hesitant about the new drug on the block when an older drug where we have more experience on its safety is available and may work just as well. And so we're sort of careful about that. Adverse drug reactions, both minor and major, occur very frequently. They account for about 1 in 20 hospital admissions, and up to 1 in 5 patients in the hospital will experience some serious adverse event related to a drug. They also cause about, of all the medical deaths that occur in patients, about 1 in 1,000 is predicted to be about related to adverse drug reactions. They can affect patients' quality of life. They also have a cost associated with them. The types of adverse reactions, there are different ways that we can think about these. The first type, one way to think about it is that it is a pharmacologic or type A type of an adverse drug reaction. And you don't need to really be familiar necessarily with these terminology, type A or type B, but a type A or pharmacologic adverse reaction is something we would almost expect. For example, you give somebody a medicine that lowers blood pressure, but their blood pressure drops very, very low. It wasn't you didn't expect or want or desire the blood pressure to drop that dramatically, but knowing the pharmacology of the drug, we just overshot it. This patient was more sensitive to it. That's the most common types of adverse drug reactions you see, more of an effect than you really were desiring. A second type of idiosyncratic effect is something that is not related to the primary site of action of the drug we give, but is either a secondary receptor or an allergic-based reaction, something that is not as predictable. It is often not dose-dependent, although sometimes it is, and it is less common, thankfully, but unfortunately sometimes much more serious. Okay, let's spend a little time looking at drug-induced blood and hepatic disorders. When we think about drug-induced blood disorders, we usually think of a drug's effect on red blood cells or platelets or white blood cells or all of them. And so we'll focus on really 4 broad areas of blood and disorders secondary to drug therapy. First group we'll talk about are hemolytic anemias. Secondly, thrombocytopenia or low platelets. Third is neutropenias where white counts go down dramatically. And finally, aplastic anemia where we have a drop in all of these blood counts. We'll talk more about these later in the year when we get into hematology as well, but important for you to have at least at this point in the curriculum an appreciation for these types of adverse events. Drug-induced hemolytic anemia can be an increased rate of red blood cell destruction. Now, we can also, when we have anemias, not so much be destruction of red cells, but can have a suppression of making new red cells. But most of the drug-related anemias that we see are this hemolytic variety. And they can be caused by either direct toxic effect or an indirect immune response or an idiosyncratic response. Probably the most common of the hemolytic anemias is genetically related to folks who have a deficiency of glucose 6-phosphate dehydrogenase. This is an enzyme that really preserves or maintains the membrane integrity of red blood cells to oxidizing agents. And so folks who have this deficiency in the face of known oxidizing agents or drugs pose the risk for the destabilization of the membrane of the red blood cell and end up having cell lysis. So it's important to maintain, to understand if folks have this deficiency, it's a sex-linked transmission mother to son. There are different variants of it. Typically, it's seen in patients who have some heritage around the Mediterranean. There is a northern Mediterranean and a southern Mediterranean type of exposure. The southern Mediterranean, or referred to as type A or African version of it, is less severe, but it does affect a larger portion of population, and their deficiency activity is only minor in being diminished. And so many folks who have this kind of presentation really don't have usually don't present with significant hemolytic anemia and exposure to drugs that are oxidizing. And so usually it doesn't really cause that much of a problem usually for them. However, folks who have a more Southern European heritage who are also affected are maybe at higher risk for severe hemolysis with these oxidizing drugs if they have this G6PD deficiency. This hemolytic anemia can also be triggered by infection or by diabetic ketoacidosis, also by some foods, including fava beans. So let's sort of not worry too much about the very detailed drugs. We'll talk about this more in the year. But there are a number of drugs that are oxidizing that are predisposed to this hemolytic anemia for patients who have this deficiency, including high-dose vitamin C. We'll see the sulfonamide antibiotics being sometimes problematic, and other medicines that we sometimes use in practice, including the antibacterial treatment for certain types of bladder infections, nitrofurantoin. There are immune mechanisms that are involved. They could be in hemolytic anemias. That can be a hapten-type reaction, immune complex, or an autoimmune reaction. And these types of reactions are similar to the same types of immune-based mechanisms for thrombocytopenia or interference with platelets, as well as other types of allergic reactions we'll talk about later. I wouldn't encourage you to get too focused on the mechanisms here, just to have an appreciation for them. So the hapten-type immune reaction, basically the drug really binds to the red blood cell surface membrane, and then we have immunoglobulins directed against the red blood cell, and therefore you have hemolysis. Typically in this presentation, hemolysis occurs most often in the patient's spleen. The immune complex formations, these are the drug or the metabolite binds to a circulating protein that forms complexes that then lead to cell lysis. An example of an older drug that can cause this are both quinine and quinidine. Quinidine, historically we used as an antiarrhythmic drug. We really don't use much anymore. Quinine is still used, and sometimes quinine can be problematic, both as an anti-malarial drug, but even for some folks who are very sensitive to this reaction, quinine is in low doses found in things like tonic water. So you want to be at least aware of that. And then an autoimmune reaction over time, seeing a change in red blood cells. And the older medicine that we used to use more often for high blood pressure, and rarely still do use in pregnant women because the data is safer in pregnancy, is this drug called methyl-dopa, but it's an autoimmune type of hemolysis that could be seen. All of these, though, are fairly rare, particularly in patients who don't have a glucose 6-phosphate dehydrogenase deficiency. Drug-induced thrombocytopenia is probably the most common among the blood dyscrasias or blood disorders that are seen related to drug therapy. And many, many drugs can cause thrombocytopenia. Thankfully, most of them that do only do it to a mild extent. It's usually not overly dramatic. And if it's a very mild case of thrombocytopenia, for most drugs, you could continue the drug if there's nothing else that is an appropriate alternative to that drug. It's also sometimes hard to pinpoint, did the drug do this or is this something else? Some folks will have viral infections that will predispose to thrombocytopenia as well. So it's important to recognize that. Typically, we'll look at thrombocytopenia as defined as when the platelet count gets below 100,000. although truth be told, platelet counts have to get below 20 or 25,000 before you begin to have real risks in most patients for serious risk for bleeding. The mechanisms of this drug-induced thrombocytopenia can include immune suppression or decreased production of platelets by suppression of thrombopoiesis, or there can even be some non-immune direct effects that the drugs can have. A pictorial of the classic immune suppression that's seen here is similar to the immune reactions that are seen with hemolytic anemia. We can also have suppression of platelets. This is direct toxic effect of bone marrow. And I think the most common, well, we'll see this with thiazide, diuretics, and furosemide, the most common of all the agents where you will see a suppression in production of platelets or thrombocytes are folks who have chronic alcohol ingestion. It is almost universal that we see in clinical practice someone who's been drinking heavily for 20 years. When they come in, we almost expect that their platelets are going to be somewhere between 75 and 100,000. And that's probably related to suppression of platelets by the drug alcohol for many, many years. There are many drugs that are associated with thrombocytopenia. Probably of all of the ones that we're most concerned about a drug-induced thrombocytopenia, it's drug-induced thrombocytopenia related to heparin. That's called heparin-induced thrombocytopenia, or HITS, H-I-T-S. We'll talk more about that when we get to anticoagulants later in the year, but that is considered, when it happens, an immune reaction that is severe with some other negative consequences for patients, and so that's kind of its own animal when we think about drug-induced thrombocytopenia. More on that later in the year. So we've talked about drug-induced problems with red cells, drug-induced problems with platelets. We also have drug-induced problems with white blood cells, and these are classically neutrophils or granulocytes, and this neutropenia can be dramatic. Agranulocytosis would be really the total or near total absence of granulocytes. Neutropenias refer to a neutrophil count that is below what we'd like. Classically, when neutrophil counts get below 2,000, we get a little concerning and we start to watch that carefully. If they get below 1,500, we watch it more carefully. Below 1,000, we consider someone definitely neutropenic. Below 500, their ability to fight infection is diminished and they're considered neutropenic. And so in practice, we're always worried about these folks who have neutropenia and their risk for infection. The most common etiology of drug-induced neutropenias are related to chemotherapy. And many of the chemotherapeutic agents, while they can suppress red blood cell function, they can suppress platelets, they are most notoriously worrisome about suppressing their neutrophil count. What you'll classically see for those subset of agents we use for treating cancer chemotherapy is that after they've completed a cycle of chemotherapy, the next 4 to 10 days is their highest risk for serious neutropenia for them, and they're posing their risk for infection. And so we'll really watch that carefully. Typically, you want to be careful about monitoring those folks very carefully in that window of time, 4 to 14 days post-chemo or post an agent that's known to cause neutropenia. There can be different mechanisms, types 1, 2, and 3. We'll briefly go through these, but don't worry too much about too much detail here. Just have an appreciation for these kind of mechanisms as they happen. One is a type 1 reaction that can happen with hapten types or immune complexes or an autoimmune kind of reaction, similar to what we'd seen before, and we see the functioning neutrophils go down dramatically. A second is accumulation of a drug or toxic concentration that inhibits the growth of new neutrophils. We can sometimes see this with, of all things, the very drugs we use to treat infections like penicillins. You can see it with certain phenothiazines, older types of antipsychotic medicines, specifically the older agent chlorpromazine or thorazine noted this when it first came on the market. And usually the way we'll treat these is to stop the offending agent, sometimes give things that will stimulate further neutrophil function, but we don't do that all that often. And finally, of all of the types of bone marrow insults that we can have from drugs, the worst of them is drug-induced aplastic anemia. And aplastic anemia is a drop in white cells, red cells, and platelets. And sometimes the drug is specific for just one of them, and sometimes the drug can be seen for all three of them. The classic drug that we probably worry about most of all for either a white neutropenic or a white blood cell count, or sometimes a total aplastic anemia, is the antipsychotic drug clozapine or clozaril. We worry more about neutropenia alone, but you can sometimes see a problem with all three of these bone marrow producing elements. And so we really worry about when we see this, we are very aggressive at its management. We look at all of the drugs that are on board. We'll stop any of them that could be likely culprits for causing them. And almost universally, you're going to get a hematology-oncology consult, a hematologist involved in the case right away to try to determine what's causing it and how we might manage it. Aplastic anemia sometimes is dependent on dose. We clearly see aplastic anemia associated with certain chemotherapeutic agents, particularly higher dose ones that can have an idiosyncratic mechanism, which is not necessarily dose related, although sometimes is. Clozapine is the classic example here. Again, this atypical antipsychotic that we still use a lot in practice, and you might say, okay, if it causes a serious reaction, then why do we still use it? The reason we still use it is because it probably works more effectively than anything else, and so we'll reserve it for those patients who don't respond to other antipsychotics. There's 2 or 3 other antipsychotics maybe they've tried, the patient's tried, and their symptoms are just so disturbing to them and affecting their functioning that they've agreed to try this agent clozapine, for which then we have to do regular monitoring of with getting regular white blood cell counts and reporting them in a national registry. There can also be immune reactions, and our treatment almost always is to stop the offending drug. Rarely, let's hope we don't need a bone marrow transplant, but we take these very seriously when they occur. Let's move on to drug-induced hepatic disorders. These are problems associated with liver function, and we'll break them down into those drugs that are toxic to the hepatocytes versus those drugs that cause a change in bile and bilirubin or gallstones or something like that, where we consider that cholestatic lesions. So we have hepatocellular versus cholestatic. Hepatocellular typically are going to affect the hepatocytes themselves. If you think about the architecture of the liver and the vessels that, where drugs will go through portal circulation, portal veins, before they get to systemic circulation, the hepatocytes around those have a high degree of metabolic activity. The drugs themselves, for example, may be metabolized to a toxin in that, and then that toxin poses a risk for those individual hepatocytes. Other drugs affect bile secretion. They may affect the sphincter, affecting the gallbladder. They may affect the risk for gallstones. They may somehow or other affect blockage in the common bile duct or some other cholestatic lesion. Let's look at the patterns that you'll see with drug-induced liver disease. Most often, and most of this is hepatocellular type of reactions, are predictable based on what we know about the dose. Sometimes it may have a long and slow onset. Sometimes it may be more rapid, depending on the nature of the dose. So, for example, let's look at a known hepatotoxic agent, Tylenol or acetaminophen. Acetaminophen at low or intermittent low doses goes through a metabolic pathway that produces inert or non-toxic metabolites. But in a Tylenol overdose acutely, someone takes a whole bottle of Tylenol, or in chronic high-dose Tylenol administration over months or years, both of those situations, the metabolic pathway is saturated for how Tylenol would normally be metabolized, and Tylenol gets metabolized to a second alternative toxic agent that's toxic to the liver. So our antidote for Tylenol, acute Tylenol overdose, is an agent called acetylcysteine. That what it really does is acetylcysteine keeps that other alternate pathway busy, so slowly the Tylenol gets out of the body through the normal pathway where there's no toxic metabolite. But if we didn't give the antidote in an acute large ingestion, or if we continue to give somebody moderately high doses of acetaminophen for days and weeks and months on end, each of those could present with more hepatotoxic risk. Having a slower onset clearly for the patient who is taking, 5 or 6 grams of Tylenol every day for the last year, and a much more rapid presentation for the patient who, if they go untreated, has a Tylenol overdose associated with a large ingestion of Tylenol. Occasionally, though, they're idiosyncratic. They're not really predictable. The drug itself is not commonly associated with hepatotoxicity, or it might be. And usually those happen when they happen idiosyncratically, happen early on. What you'll often find is that for many hepatotoxins, not always, but for many, they're not necessarily fatal. Tylenol can be fatal, absolutely fatal. But for other things, for example, they cause a little bump in the liver enzymes, AST or ALT or ALK-Phos or something. And that's like a short issue of causing some reversible hepatotoxicity, hopefully reversible, that may or may not be able to improve once you remove the offending agent. But that's always our hope. So the types of pathological presentations, one involves central lobular necrosis. And if you look at the portal vein here on this graphic, you'll see in the center of that lightened area around the hepatocyte, you'll see that everything around that blood vessel was interfered with. And we'll see this with Tylenol overdose, with halothane. And this type of central lobular necrosis, this actually is often not reversible. And so you want to make sure we address this as soon as we can to prevent the problem happening in the first place. We can also find that with longer-term liver injury, you can see this steatonecrosis, or this fatty liver, and this is classically seen after 20 years, for example, of heavy alcohol intake, that the liver has a lot of fat, accumulation of fatty acids and hepatocytes, often with a lot of necrotic tissue there, and that is, even on autopsy, you can visualize a liver itself almost slimy in that it's got so much fat or steatonecrosis associated with it. We also have concerns for other types of liver toxicities. One type of concern in children in particular is an aggressive hepatocellular disease called Rye syndrome. It's associated with certain drug therapies in the presence of viral infection, typically aspirin in the presence of viral infection in children. And so this is the reason why we no longer use aspirin in children, because of this risk for Rye syndrome. Typically what you'll see is for children, we will use either acetaminophen in low to moderate doses, or we will use ibuprofen as the two standard treatments for getting rid of fever or mild to moderate pain, not aspirin. We can also have toxic hepatitis. It resembles viral hepatitis. A lot of drugs may produce a metabolite that may or may not cause some toxicity associated with them, or even if they don't themselves, the metabolites trigger an immune and autoimmune kind of reaction, even though the metabolite itself may not be toxic. And then cirrhosis, to sort of cap our sort of overall quick discussion of hepatocellular liver toxicity. Cirrhosis is a long-term consequence typically of hepatotoxic reactions, typically over time. Some drugs long-term can cause this. We can also see this with very high dose of the fat-soluble vitamin A. But more commonly, you think of cirrhosis as folks who have had either chronic liver disease associated with alcohol and chronic alcohol ingestion, or cirrhosis secondary to hepatitis B or hepatitis C, untreated hepatitis B or hepatitis C infection. Let's switch gears a bit, still staying in the liver, looking at cholestatic jaundice. Cholestatic jaundice we're going to look at as an issue affecting bile. You may see either the risk for gallstones or gallbladder, sphincter of OD spasms, or something that will interfere with the ability of the free flow of bile from the gallbladder. Probably the drug I think of most often associated with gallbladder or gallstones is estrogen. Some women, particularly older women who are on estrogen, seem to have a higher risk for this. And so older women, particularly older obese women who take estrogens, are associated with more history or likelihood of gallstones. When we think about the kinds of drugs that are associated with hepatotoxicity, there's a few slides here. I'll just sort of go through the drugs very quickly. It's not expected at this point that you will know this, but over time, as the year goes on, some of these drugs, it'll be very common for you to kind of watch for them. And even though we've listed some of these drugs, I'll stress which ones are the most likely to really be hepatotoxic. One is high-dose acetaminophen or Tylenol. That's clearly hepatotoxic in overdose, and so we're often very clear about limiting exposure. In typical adults, the FDA has, over the last couple of decades, continued to decrease what they recommend for a ceiling dose of the most people should get, and now that recommended ceiling dose is somewhere from 2,400 to 3,000 milligrams per day. It used to be 4 grams per day, 2,600 milligrams to 3 grams per day. Now, it used to be 4 grams per day. Before that, it used to be 6 grams per day. Alcohol, ethyl alcohol ingestion long-term clearly is hepatotoxic. Aspirin has a low risk except in pediatrics, where we worry about the condition of Rye syndrome we talked about already. There's a number of other drugs we use in clinical practice. Some of the antidepressants can. There's a drug we use for ADHD, Strattera, that can. Some of the anticonvulsants like carbamazepine or Tegretol can. Clozapine and the antipsychotics can. Abuse of cocaine can cause hepatic necrosis. There are drugs that we don't use much anymore, but disulfiram or antabuse, an agent that for patients who have a history of alcoholism that want a deterrent for using alcohol, it might be consideration for them. Sometimes the nonsteroidal anti-inflammatory agents, while rare, can cause some hepatic injury. That's quite rare, though. The antipsychotic phenothiazines, though, are more common, and the anti-epileptic drug phenytoin can sometimes cause that, too, although that's usually a relatively rare hypersensitivity type reaction. Other salicylates like aspirin, typically again in children, is the greater issue. The anabolic steroids, particularly testosterone, can cause hepatocellular injury, and ethinyl estradiol, and to some degree testosterone that's converted to estrogen can cause a more cholestatic kind of problem as well. Tacrine, an agent we don't really use much anymore, largely replaced by other treatments for Alzheimer's dementia, and valproic acid, which is an agent we use both for seizure control and also for bipolar or mood disorders. Okay, let's take a break and now start to think about drug use in pregnancy. Some of these terms we've already talked about, but we defined already teratogen as a drug or environmental agent that has the potential to cause abnormal fetal growth or development, and the capacity of an agent to do that is considered its teratogenicity. When we think about causes of birth defects, most of the time we think of a situation where we haven't really pinpointed a specific cause. Genetics probably accounts for about a quarter of them. or genetics alone. Drugs, only 2 to 3% of them. But the difficulty we often have is we may be faced with a situation, in a particular situation, where we can't actually pinpoint what the exposure was at what point in the pregnancy that could have contributed to whatever the fetal malformation or issue was. All of the issues, though, with teratogenicity come to a head when we think about the thalidomide disaster in the early 1960s. Thalidomide was a medicine used in the first trimester of pregnancy because it reduced anxiety and helped with nausea and vomiting with morning sickness, and was used to a pretty widespread degree in the United Kingdom and in the United States. And in 1960-61, when it was being used, we didn't realize, or clinicians didn't realize, the potential risk of it. What happened was that for women who took it in the first trimester, about a third of infants that were born had some limb defects, some quite traumatic. And this prompted the legislation in 1962 requiring that medicines be safe and effective prior to being put on the market. If you're a fan of either BBC or public television, you may have seen a program called Call the Midwife, which is set in the late 50s and early 60s with a group of midwives in London. And they've had, in their fourth or fifth season, actually had a couple of quite poignant episodes regarding the thalidomide disaster, and pretty much had a pretty excellent approach to how the take really was. It's pretty realistic about how they presented the disaster and what implications are. The lessons among all that we've learned with thalidomide is that the animal model testing that had been done prior to thalidomide being put on the market didn't predict this problem. And so animal model and the way animals will metabolize or utilize drugs may be different than humans are. Here's an example of such a case. And so we are always very cautious about using any drugs during pregnancy. The natures of teratogenic effects can vary from very mild to almost undiagnosed to severe, even leading to miscarriage. Anatomical malformations are more likely to happen in the first trimester of pregnancy when that particular organ system or set of tissues are being developed. Functional changes are more difficult to recognize, as are behavior and cognitive changes. Both of those may not be noted until the infant is a couple of years, or the child's a couple of years old or older. The mechanism of teratogenic effects varies, but most of the time we think of it as the agent having some direct effect on embryonic cells or somehow affecting maternal tissues or nutritional status of the fetus. And a classic example where we know that, for example, spinal cord deficits in a developing fetus can be problematic with the combination of a folic acid deficiency in the mother plus exposures to certain drugs. Mostly we think of these as anti-epileptic drugs, which can cause this neural tube deficit. Sometimes, though, the teratogenic effect isn't observed until 20 or 30 years after birth, and the classic example here is that women in the 1950s who took diethylstilbestrol, their daughters 20 years later have a higher risk of vaginal cancer. So sometimes these effects are quite latent, and we don't know about them for almost a generation. The nature of fetal malformations do occur in between 3 and 6% of pregnancies. It could be a function of drug. It could be a function of infection. For example, viral infections like German measles, for example, are really problematic. Could be a function of genetics, of pollutants or toxic exposures. The particular fetal malformation or organ system damage is most common in the first trimester when that system is developing. So, for example, in weeks 3 to 6, where the heart's developing, if a drug is known to cause fetal malformations for heart valves, that's when it's likely. If the exposure was during the 3rd to 6th week of pregnancy, then that's likely when the biggest risk is going to be for the exposure of that drug. LIMS 4 to 7, thalidomide, for example, when it was given weeks 4 to 7, that was probably the risk for exposure. Cleft palate, week 6 to 8, we know, for example, phenytoin or dilantin has a higher risk in pregnant women to cause cleft palate in the newborn, particularly if the exposure is in that 6 to 8 window. So the concern we have, among other things, is that probably the greatest risk for drugs in pregnancy is that first trimester. And often, if you think about it, it's often a time when the woman does not know that she is pregnant. And so as clinicians, we always have to think, could the woman in front of me, who is at all in childbearing age, could I be exposing this woman with the drug I'm prescribing to a situation that's a known teratogen should she be pregnant? And so we always rule out pregnancy in women of childbearing age. We're going to use any agent, but particularly anything that could conceivably be a risk. And we also want to use drugs that have the lowest estimated risk for causing fetal malformations. There's not a lot of great data. Most of this is on case study. The only example that we have that's a little more definitive that I can think of is when you have a clinical trial that compared placebo to that drug in pregnant women and measured or looked for any type of fetal malformation. And as you can well imagine, it's highly unethical to do that type of study in most circumstances. The only time I can remember in my career was I was working at a setting in the 1980s and early 90s where we had a study in pregnant women for zidovudine to prevent or to diminish the risk for transmission of HIV from a woman to her fetus and to a newborn. And so women signed up to either get placebo or zidovudine during pregnancy, and actually we had to stop the study early. We didn't, but the study folks did, because it was found that zidovudine reduced the risk of transmission from mother to newborn by 2/3. And it was then considered unethical to not give a pregnant woman zidovudine. And so here's a study that was sort of framed and done that way. And you kind of think in practice, we don't have too many examples of that, but the risk for not treatment was so high that it outweighed the potential risk for fetal malformations. And in fact, in the study, there were really almost no fetal malformations. I don't think there was really anything that was problematic to the newborn with zidovudine, and so it's considered, it was considered at least at that time as an appropriate agent to use for women who were pregnant who are HIV positive. When we think about drugs in pregnancy, you want to think about the factors that influence teratogenicity. Those include the genetics, embryonic stage and exposure, the medicine we're using and its dose, other exposures, the timing of the exposure, making sure nutritionally the mother is nutritionally complete, particularly folic acid is probably the big one we think of. And you want to be careful about the nature of what we give during pregnancy. And so the medicines we'll give to a woman of childbearing age or a woman who is known to be pregnant, we try to limit those to those that have a clear benefit and a very low risk. There are times when we're sort of debating that risk and that benefit, but for the most part, we try to limit drug therapy whenever possible. We think about if we have to give a drug, we think about in pregnancy, we think about does the drug cross the placenta? The same principles we talked about of crossing any membrane are true here. A large molecular weight drug, for example, does not cross the placenta nearly as easily as a low molecular weight drug does. If the drug is highly bound to plasma proteins, it also won't cross very well. If a drug is fat soluble, it will likely cross, whereas a water soluble electrically charged drug won't. And so, as such, the kind of scenario we're going to look at is if we're faced with a circumstance where we have to make a decision between two drugs, it is probably safer to pick a larger molecular weight, electrically charged molecule as opposed to something that's smaller and fat soluble. The classic example has historically been Women who are pregnant are at higher risk for deep vein thrombosis and a pulmonary embolism. If they have a deep vein thrombosis, we have to treat that during pregnancy. It is much safer to use the heparins, the injectable heparin. That is a very large molecular weight, somewhat electrically charged molecule in pregnancy compared to using some of the oral anticoagulants, particularly the one we're worried about in pregnancy is warfarin or Coumadin, which is small molecular weight, fairly fat soluble, will cause a risk to the fetus. Quantifying that risk, though, is difficult. In the 1970s, the FDA introduced risk categories for drugs in pregnancy, and we've been waiting for the last decade for updates to those, and we got them about 2 years ago. Let's think first about what we do know and what we don't know about drug risk in pregnancy. There's probably more we don't know than we do. We do probably know some preclinical animal testing that's done, the results of that, but those, as we learned with thalidomide, don't always predict teratogenicity. There's a study done in the early 2000s that looked at the drugs approved for the prior 20 years and recognized that for 90% of them, we had not really adequate information about the teratogenicity risk of those drugs. When we think about drugs crossing the placenta, again, keep in mind what's going to not cross the placenta. What we really want are large molecular weight or electrically charged or highly protein-bound drugs. That's really the only drugs that are going to cross are those that are not protein-bound, that are smaller molecular weight and aren't electrically charged. When we think about where drugs go, we think about the maternal, the fetal compartment, really the area where the amniotic fluid and the fetus are residing across the placenta. That's its own reservoir of potential drugs, and we're really doing our best to try to really limit the exposure of drug to that area. So we'll look at the pharmacokinetics, particularly the distribution of drugs as it relates to whether or not it's going to be a potential risk to the fetus. The concepts of fetal transfer of drug to the fetus is partly that the placenta serves to some degree to protect the fetus. It's a little thicker in early pregnancy, but the concept that the placenta is a barrier that's going to be impervious to drugs is really erroneous. So you want to just be aware of, in practice, we really first look at limiting drug exposure entirely during pregnancy, or even in early pregnancy when we don't know the woman is pregnant. That's always a concern. Otherwise, if you're going to order something or give something to a woman who's pregnant, you probably want to talk with your prescriber, and they may work in conjunction with the obstetrician and the specialist. Let's say it's procedure controlled, a neurologist, or any other specialist that's kind of managed the risk-benefit ratio of giving the drug during pregnancy. The data that has been evaluated that we make decisions about regarding safety of drug in patients is mostly case study based or animal studies. There aren't really, with the exception of that zidovudine study in HIV we talked about, there are not many studies that are like that. So the data is not very good to start with. And it's also pretty well recognized that despite the fact that women know not to take medicines during pregnancy unless they're prescribed, we still have a fair amount of women who are on a number of drugs. Now, thankfully, most of those are things like vitamins that are prescribed or iron supplements or maybe some analgesics, but we need to be careful about analgesics, antibiotics, and other medicines we use during pregnancy. And let's say a woman does have a urinary tract infection, for example, during pregnancy, then when we decide to treat that, we're going to use agents that are known to be safer in pregnancy than agents that may be more risky to the developing fetus. Prior to 2015, the nomenclature we'd use for evaluating risk for drugs in pregnancy, the FDA had this category rating system of A, B, C, D, and X. And even though those are no longer officially approved by the FDA, clinicians still utilize this nomenclature in having a somewhat quantitative assessment of risk for a drug in pregnancy. And so clinicians still use these guidelines or older categories in place. And so basically when they were developed, basically a Category A drug was indicated there were control studies that failed to demonstrate a risk, and there's almost no drugs in practice that are Category A. Category B is usually the best you could expect to see a drug to do, and that the combination of animal models and whatever studies that have been done, including case reports, indicated there wasn't a real problem associated with the drug. And so Category B was about as safe as you could get. Category C is that there are some studies that suggest there may be a problem. If you have a Category B drug you could use in place of a Category C, then you're going to pick a Category B drug. But a Category C, there are times when that might make sense to use a Category C drug. A Category D is that there's clear data for fetal risk, but the condition, if it's really significant, it might be acceptable to consider using a Category D drug when the condition needs to be treated and there's no alternative. An example here of use of Category C or D drugs in practice is a woman who has a seizure history that's significant, and you need to control the seizure, but because the seizures themselves can increase the risk for a miscarriage by a great degree, and yet the drugs themselves may cause fetal malformations. And so you weigh the risk and the benefit of giving the drug for controlling seizures but preventing seizures compared to the risk the drug may have in causing some fetal malformations. And Category X are drugs which are known to be teratogenic, and there's never a role to give them. And the classic example there is a very common class of drugs we use in most adults over the age of 40, and those are the statin or cholesterol-lowering medicines, the HMG-CoA reductase inhibitors like atorvastatin, Lipitor, or rosuvastatin, or Crestor. These agents are Category X drugs, which are, because they affect cholesterol synthesis, and cholesterol is necessary for making membranes, they're known to be teratogenic in a newborn. These category ratings, though, were pretty much phased out by the FDA in late 2014 and replaced by a different system of categorization or quantification of risk. In fact, the labeling changes that happened over the last 3 years or so are probably a little more precise in one regard, but clinicians are upset that the old number system aren't there because it was hard to compare agent A against, agent 1 against agent 2 against agent 3. But the labeling in the old nomenclature of drug labeling had categories for issues about use in pregnancy, labor and delivery, and nursing mothers. And the categories now include the use in pregnancy, use in lactation, and then a category for both male and female reproductive potential. And so there, for example, things that might affect sperm count for men, for example, would be listed in this portion of the package labeling. These changes were really promulgated after decades of sort of discussion from the FDA in the recognition that the older letter categories were not really the best evidence that supported that quantification. And as clinicians, it's helpful to have somebody else to quantify a risk for us to make it easy to make a clinical decision. So the abandonment of these categories by the FDA has left clinicians kind of a little less clear about how to quantify risk among these agents. But on the other hand, the FDA was right to do this in the sense that there was this false sense of security with this old ABCDX system that patients sort of put too much trust in, perhaps because the data wasn't really that great. There's a couple of slides here that sort of outline what the FDA's website said specifically about that. I encourage you at your leisure to sort of look at that, but we've pretty much discussed this. More on that FDA statement, and yet more on that. The older terminology, which category B and maybe some C drugs that people think of as more or less safer drugs to use in pregnancy are sort of listed here. These are drugs that, as we go through the year, it'll be more clear about which drugs are safer versus less safe. But, for example, if you have to use an antimicrobial, antibacterial agent in a woman of childbearing age, we're more likely to pick a penicillin or a cephalosporin, which is related to penicillins, because those drugs have a reasonable body of data. They've been around for 30 years or more with data in women who are pregnant. And those are the drugs we typically use for treating bacterial infections in women of childbearing age if they potentially could become pregnant and really do need an antibiotic. The category D and X drugs are listed here, the older categories which aren't used, but these are really considered higher risk drugs. And in these, for example, are some other antimicrobials, classically the tetracyclines, doxycycline, tetracycline fall into the category D group. And unless there's a real overwhelming need to use tetracyclines, because tetracyclines have an effect on bone and bone structure, among other things, are really drugs that we don't want to use in a woman who's pregnant because of the risk it has for the developing fetus. There are other drugs which in pregnancy there's a lot of caution about how we use them. They sort of drugs that fall in between. But all of these, whenever you're looking at giving an agent that is going to be used during pregnancy, there's a lot of question or concerns for risks. And as clinicians, really as a mid-level provider, you want to bump that decision up to your physician and or to the specialist or the obstetrician. And as a clinician at the mid-level provider level, this is a little out of, you should be a little out of your comfort zone on which drugs to use in a woman who's pregnant. You can begin to outline your plan, but in these circumstances, you really do want to double check with other providers before you sort of walk out on a limb and dose some of these medicines in a woman who's known to be pregnant or could likely be pregnant. The types of adverse effects after fetal exposures, we've kind of talked about some of these things already, and some of them are more functional exposures or other things like seizure risk or future reproductive dysfunction. There are a lot of things to think about. One of the things that's very common with a number of exposures during pregnancy is a low birth weight. That's a classic situation that we'll see, particularly in women who smoke. Let's move on to drugs in lactation or breastfeeding. And when we think about this, the big issue we think of with drugs in breastfeeding or women who are breastfeeding is we want to do everything we can to encourage that woman to continue breastfeeding. We don't want to interfere with breastfeeding. And so as a clinician, if you have a woman who's breastfeeding, typically what you'll do is you'll refer that woman to a lactation specialist. If you work at a hospital that has an obstetric unit, there almost always will be a lactation specialist that will be available to sort of go through these issues with you. But basically what we're looking at doing for a woman who's breastfeeding is, except for a couple of outlying real critical drugs, most of the time we can work around the drug therapy question and allow the woman to continue breastfeeding because the benefits of breast milk over bottle feeding or formula feeding is dramatic. So when we think about which drugs we're going to use in a woman who's lactating, we think of the nature of the drug themselves, some clinical considerations, some drug-specific issues. As we alluded to already about drugs crossing membranes, we think about the things that are going to get into breast milk and cross membranes into breast milk are drugs that are relatively small molecular weight or fat soluble, but otherwise those drugs really won't get into breast milk. What is important to think about is what gets trapped in breast milk. And so medicines that are particularly weak bases, breast milk is a little more acidic than the blood, and as such, based on the pKa of the drug, it can start to pick up hydrogen ions in breast milk that it didn't pick up in the blood, and all of a sudden it crossed into the breast milk as an unionized drug, but when it's in the breast milk, it's ionized, and lo and behold, it doesn't get out of breast milk, so the levels go up. And there are a number of drugs that are relatively weak bases that will exhibit this phenomenon of having higher concentrations in breast milk than they do in the serum. An important consideration, one of a number of things to think about when we're giving drugs to a woman who is breastfeeding. Other things we think about is whether the drug is protein bound. So if it's highly protein bound, a lot of it won't get into breast milk. We also think about the distribution of drugs from maternal tissues through the blood, ultimately into breast milk, and then expelled into the infant. And so we're really thinking about the infant's exposure to the drug that is in the breast milk. That's really the issue. So there's a few things we're going to think about there. The clinical considerations really fall into a couple of broad categories. But the first things we think about is, does a drug get into breast milk? And so if it doesn't get into breast milk at all, it's pretty much of a non-issue for the most part. But even a small amount of drug in the breast milk could be an issue. So the next question to ask is, okay, if it even is in breast milk, even in small amounts, is that a risk for the infant? So we assess that. For example, there are many medicines that are pretty innocuous and not really problematic for an infant exposure. Classically, we'll think of, for example, the H2 blockers like ranitidine or famotidine, Pepcid or Zantac, which are used very commonly in pediatrics for 20 years without any problems for kids. And the amount that gets in breast milk is still much lower than the dose would give therapeutically to an infant. And so if a woman has peptic ulcer disease and is taking, for example, Pepcid or Zantac, most clinicians say, hey, it's not really an issue. If the infant gets a little of that, it's probably not a problem, and that woman should still be encouraged to breastfeed. There's other issues we think about is the quantity of the milk consumed, the age of the infant, are they able to handle the drug at the age the infant is, what experience we have with that drug in infants, and whether or not there's any other toxicities associated. There are a number of things we can do to sort of manipulate that by the timing of breast pump and breastfeeding, maybe breast pumping at a certain window when the levels are going to be very high and expelling that. But that's pretty complicated for women to do. For the most part, a lactation specialist could help you work through and help the patient work through some of these issues and making some decisions about, A, do you have to change drug therapy while she's breastfeeding, or B, are there other things you could do, or C, you're not really worried about it, continue breastfeeding. So short term, the mother can pump and discard. They can choose drugs with maybe shorter half-lives or drugs that don't get into breast milk. That's even a better thing. So all of these are sort of things to think about. There are also drugs that can impact on the supply of breast milk. Some drugs associated with decreasing supply of breast milk, others that may increase supply. There's sort of some examples are listed here. But that's an important issue if a woman's breastfeeding and taking one of these medicines that's associated with reduced supply of making breast milk. And the classic of all the drugs that are listed here, probably the biggest one of the estrogen or hormonal contraceptives that a woman may decide to be on postpartum if she doesn't want to get pregnant again. That could actually impact on her ability to make enough breast milk to be able to nurse her child. There are some drugs that are considered by the American Academy of Pediatrics as always contraindicated for use in women who are breastfeeding. And most of these are drugs of abuse. So cocaine, heroin, any opioid actually is considered a potential problematic issue. Amphetamines and cancer drugs for chemotherapy. Our lithium is another one where we would avoid use in breastfeeding. So there's, of all of the drugs, these are sort of a standout no. So if a woman needs analgesia, for example, while she's breastfeeding, most clinicians would try to avoid using opioids, for example, for analgesia and consider something else. If the woman has ADHD, then we want to avoid amphetamines with that woman while she's breastfeeding or decide not to breastfeed. Let's go on now to talk about other types of toxicities. This one is kidney toxicity or nephrotoxicity. As we think about drug toxicity in the kidney, it's important for us to recognize the functional unit of the kidney being the nephron and where the sites of vulnerability are for drugs to cause toxicity for kidney function. So you probably remember this graphic or something like this graphic in your anatomy and physiology coursework, but the glomerulus is the site of passive diffusion of drugs across the Bowman's capsule into the lumen of the nephron, where multiple things happen throughout the course of the nephron. Think about first what the normal renal function is. The kidneys do a lot of things. They maintain acid-base balance, endocrine function, including renin and erythropoietin. They have metabolic processes, including the activation of vitamin D. They will have some drug metabolism, including metabolizing insulin and corticosteroids. They also have other enzymatic function. They're responsible for water and electrolyte homeostasis or balance, and they're responsible for excretion of toxins or other substances. So we'll find that drugs can affect any of these or all of these aspects of renal function to one degree or another. We'll talk about drugs that actually we use to adjust acid-base balance, drugs that we use to block or address renin processes. We'll use replacement for erythropoietin by giving synthetic erythropoietin. We have metabolic processes that we can influence outside of the kidney as well, including giving an already active form of vitamin D. And we'll look at processes to maintain electrolytes by supplementing electrolytes or giving electrolyte binding agents as well. So all of these are sort of factors that we can have some influence in, but it is ideal when the patient's own kidney is functioning at a high level to allow for the body to really do all of these functions instead of us artificially adjusting or affecting them. One thing we want to do before we start is to recognize what is considered normal or appropriate renal function, or assess where someone's renal function is. And the renal process we're most concerned about, particularly as it relates to drug excretion, is something called glomerular filtration rate. And this is it's a theoretical volume, but it's considered the amount of plasma that would be cleared per minute via capillary wall into Bowman's capsule space. And we've talked already a bit about glomerular filtration rate, but typically we're going to measure this in milliliters per minute. The surrogate marker of GFR or glomerular filtration rate is creatinine, and so we'll do something called a creatinine clearance, and that process, creatinine is a byproduct of a metabolic process, and so men produce typically a fair amount of it, women a little bit less, and so the estimates we'll use account for whether it's a man or woman in part to reflect how much they produce creatinine typically in the course of a day. We'd consider normal creatinine clearance as a creatinine clearance greater than 80 mils per minute, and severely impaired creatinine clearance less than 10 mils per minute, considered end-stage renal disease or ESRD. And there's a sort of a range between there listed on this graphic. Drug-induced nephrotoxicity, or how drugs can actually cause renal failure, it's actually surprisingly common in the hospital. This report that I'm looking at here says it's 3 to 6% of hospital admissions are due to adverse reactions related to nephrotoxicity, and that accounts for about 7% of adverse events in hospitalized patients. In the intensive care unit, I think we see more than 7% of folks go into renal failure because of how they're managed. It could be either the drugs doing that, or it could be that they're hypotensive or have a situation where their blood pressure goes down, and so perfusion to the kidney is impaired, and that ultimately results in nephrotoxicity. There's not one universally accepted way that we classify nephrotoxicity, but we'll classify them in a couple of different ways, and we'll talk about that in a bit here, but more importantly, we'll talk about that in greater depth later in the year when we get into therapeutics. The mechanisms of drug toxicity, first of all, let's look at the nephron and then look at some slides here and talk about a couple of different places where we see the nephron to be vulnerable to toxic drugs. So one issue that we need to think about as we look at drug toxicity to the kidney is to keep in mind that renal blood flow it represents about a fifth of total cardiac output. So the kidneys themselves, first of all, get a large exposure to drugs and to toxins by that very nature. There is specifically regarding Bowman's capsule, there's specialized renal hemodynamics, meaning that the blood flow and the pressure into Bowman's capsule and exiting from Bowman's capsule in the glomerulus are important in maintaining that transfer, passive diffusion of drugs and toxins. So too little pressure, too little head pressure of the blood going into Bowman's capsule, someone who's hypotensive, for example, is associated with really reduced renal function, and too much head pressure there as well, particularly long-standing hypertension, can be problematic long-term and affecting the integrity of those membranes. We also have tubular, luminal, and contraluminal transport epithelial cells cause drug accumulation. And accumulation of drugs in the tubule, particularly if they're toxic, can cause interstitial or tubular necrotic situations where the drug or the toxin accumulates in the tubules, and that causes acute tubular necrosis, or called ATN. Water is reabsorbed from the tubular lumens and concentrating again. Nephrotoxins around these sites could also be associated with some impaired kidney function or affecting the function of that nephron. And there's also a lot of metabolic activity, particularly in the distal tubule, that requires a lot of energy to metabolize certain drugs, and that energy can get released as part of that metabolic process, and lo and behold, what you can end up with actually is further risk for toxicity. We also have the cytochrome P450 enzymes that may produce toxic metabolites in the proximal and distal tubule. Those can also be sites that make the nephron vulnerable to toxicity. And the urine acid acidification in the intratubular process may result in precipitation and crystals in the urine, and those crystals can cause an obstructive process, and that obstruction not only irritating to that area, but also things back up and folks get into renal failure because of that. So probably the things we'll talk about, and we'll talk in greater depth later in the year about, is the etiology of whether a renal failure that a patient presents with is what we call pre-renal, happening before the kidney, renal happening in the kidney, or post-renal happening in the collecting ducts in the bladder. Pre-renal is classically hemodynamic mediated renal failure. And this happens when we have a low blood pressure, or we have factors that interfere with prostaglandins that maintain blood flow. So we can have either any drug that lowers blood pressure too much, or if a patient is in septic shock, all of that can cause renal failure. But drugs can contribute to that too, and the head pressure in the glomerulus is affected by ACE inhibitors, by non-steroidal anti-inflammatory drugs, and a few other drugs that affect renal vasoconstriction or vasodilation. There are also processes within the kidney itself, glomerulonephritis or nephrotic syndrome. Drug-induced, not very common, but it does happen. It's usually an immune-based process, and that really affects the integrity of the membrane and allows often a great loss of albumin into the urine because the integrity of that membrane is lost. so it's not really as fine. It allows large particles, including proteins, to get through. If the process is in the interstitial space, tubulointerstitial disease, interstitial nephritis happens in about maybe up to 10% or so of acute renal failure patients, and they'll present with other symptoms as well. There are a fair number of drugs that can cause this. This is not as common a cause as the hemodynamic mediated process we talked about earlier, but does happen, and so we have ways, and we'll talk more in the renal block about how we differentiate if a patient's presenting with a pre-renal, a renal, or a post-renal type of scenario that helps you pinpoint the etiology of what caused it. But there are drugs that can cause this interstitial process to be a problem. And finally, obstructive nephropathy. These are where there's a crystal. Really, we think of crystals depositing in the collecting ducts or somehow causing urinary obstruction of some kind that backs things up. And there's a fair number of drugs that potentially can do that as well. Let's talk about some other common adverse effects with drugs as well. Let's move on to a few things, and we'll go through these a little bit more briefly. Many of the drugs that we use in practice have the potential to cause a drug fever, and those actually include antibiotics that can cause a fever, which make it very difficult when we're trying to manage a patient who has persistent fevers while on antibiotics. The question often becomes in that circumstance, is there fever because we picked the wrong antibiotic and we need to use a different antibiotic, or is the drug itself causing the fever? And there are some other sort of tools we can use in clinical practice to help differentiate which of those two scenarios are the case. There are drugs that can affect someone's cognition. There are a fair number of drugs that can cause depression. Here are a list of some of them. Some of the older antihypertensive drugs can do that. Some of the sedative hypnotics can do that. More drugs that can cause depression. Sometimes the opioids can do that. There are other drugs, including estrogens or withdrawal of stimulants, that can do that as well. Drugs that affect metabolic processes, electrolytes and glucose levels, can also affect someone's mental status. And as such, drugs that affect glucose, including low blood sugars or high blood sugars. Low blood sugars, typically the drugs we use for treating diabetes. High blood sugars, classic in this example, are the drugs like prednisone, are all associated with changes in glycemic control. There are drugs that contribute to dementia or memory loss. The antihypertensives, some of the drugs we use in neuropsych as well, can do that, as well as the drugs that are antimuscarinic or anticholinergic. There are drugs that cause delirium or behavioral toxicity. These classically can pose a risk for delirium in patients, and so we're careful about some of these drugs that predispose to this type of cognition changes. There are a lot of drugs that are a little bit stimulating and can cause insomnia, so we're aware of those. Sometimes the insomnia is because it's a direct stimulating effect. Sometimes it's just like we gave someone a diuretic at bedtime and they had to pee a couple of times in the night to get up to pee, and that interfered with their sleep. There are a number of drugs that can affect cardiac rhythms. We'll talk about more of this later in the year, but we're particularly concerned about QT prolongation on EKG, which predisposes to a life-threatening ventricular arrhythmia. We also worry about slowing through the conduction through the AV node in the heart. There are drugs that can increase heart rate. That can be a problem for someone with coronary artery disease. And there are drugs that slow heart rate or have a negative, what we call inotropic effect, meaning it makes the heart not beat as strongly. That can be a problem for someone in heart failure. So we'll talk about some of the examples here, but these are really 30,000 foot. Just have a recognition that these things happen, and later in the year we'll get much more specific with these things, with these particular types of problems. So drugs that prolong QT interval, there's a great list, many list of these drugs, but the prolongation of the QT predisposes to ventricular arrhythmias, and that's a real problem for us in clinical medicine. Lots of drugs are listed here. Here's a partial list, some of the antipsychotics. The antidepressants can do. There are other drugs that can prolong QT, include antimicrobials, commonly used macrolides and fluoroquinolones are a problem. And most of the drugs we use for controlling heart rhythms actually themselves can worsen them, including worsening the QT interval. So that becomes problematic. We have drugs that will slow conduction through the AV node, and in fact, we sometimes use this for our advantage. These are the very drugs for patients who have a condition called atrial fibrillation, where their upper chambers are quivering, and a lot of those beats are getting to the ventricles. We want to slow conduction from the atria to the ventricles. We intentionally slow heart rate down in the ventricles by using one of these drugs, calcium channel blockers, the beta blockers, or digoxin. But you can have too much of a good thing, and so they can have additive effects. And if somebody already has slow AV nodal conduction, we add these drugs, we can actually cause something called heart block. There are drugs that can increase heart rate, and so someone with coronary artery disease, that can be a problem. The stimulant drugs can do that. Theophylline, which is an older agent used for asthma, COPD, that's related to caffeine, can do that. Beta agonists can do that. And sometimes some of the drugs we use to lower blood pressure, the baroreceptors in the aortic arch naturally respond to that antihypertensive with increasing heart rate to maintain cardiac output. So we call that a reflex tachycardia. We have to be aware of that as well. There are drugs for folks who have heart failure that can actually make their heart failure worse. There are drugs that affect the strength of conduction of contraction in the heart. And there are many medicines that also cause fluid retention that can be problematic for someone with heart failure. There are many drugs that have the potential to lower seizure threshold. So someone with a new onset seizure comes in the emergency department, we classically will get an electrolyte panel, and we classically will get a drug tox screen and query them about any new drugs they've started. Because we don't necessarily need to label somebody as having a long-term seizure problem or epilepsy when we know there was a particular agent that caused it, and the answer to our problem is not to put them on lifelong epilepsy therapy, anti-epileptic therapy, but instead to avoid that exposure. There are drugs that can make asthma or chronic obstructive pulmonary disease worse. We already alluded to this as an example earlier on with the use of a non-cardioselective beta blocker. A beta-2 blocker could actually worsen asthma, COPD. There are other drugs that can do that as well. There are many drugs that can interfere with diabetes. The worst of them probably are the corticosteroids like prednisone. Prednisone, because of its cortisol effects, will actually cause a patient to lose good blood sugar control. The blood sugars will often get higher. That's a common scenario we see in clinical medicine, and you just, as a clinician, need to be aware of that. There are drugs that can cause movement disorders or different types of tremors or dystonic reactions. We'll talk more about those later in the year, but particularly many of the drugs we use in psych mental health can do that, and so we need to be aware that those kind of problems can happen. There are also drugs that will have affect the ability of folks to be mobile or increase their fracture risk if they should fall. There's examples are listed here, but there are drugs that affect bone density over time. Prednisone is one of them again. Some of the drugs we use for seizure control also affect the metabolism of vitamin D and therefore affect bone density as well. Other things that can affect patients' mobility are drugs that produce neuropathies, drugs that cause vertigo or risk for vertigo, drugs that are otherwise sedating to people, and so they are less likely to get up and move around because they just feel very sedated. There are drugs that are antihypertensives that we worry about something called orthostatic hypotension, meaning when they get up quickly, they can't respond, their blood pressure doesn't respond as well, and their blood pressure goes down, and they get dizzy, and they fall, and maybe have a risk for a fracture too. There are a lot of drugs that are constipating. The worst of them probably are the opioid analgesics. that can cause sometimes very severe constipation, as well as anything with anticholinergic properties. There are drugs that contribute to urinary incontinence. There are different types of urinary incontinence we'll talk about later in the year, but some drugs that can actually make that worse. There are drugs that are difficult for men who have enlarged prostates and will cause or risk causing urinary retention. Those include antimuscarinic or anticholinergic drugs and other drugs that have a lot of antimuscarinic properties, as well as sometimes the opioids can do that as well. There are other things we think about in general that increase the risk for falls or fractures. The many lists are here, and the kind of things that we'll see commonly in practice. And so if someone comes in who has a fall, often a pharmacist will work with the team, in the hospital at least, to look through all the list of things they're on and to say, did any of these medicines they were on contribute to falls, and then how do we manage that in the future? It may be the risk assessment of continuing that therapy may change, and we decide from this point forward we don't use that same drug or at that dose or something like that. There are some drugs that actually make high blood pressure worse, hypertension worse, the nonsteroidals, and sympathomimetics that are found in cough and cold preparations can do that. So those are some of the sort of disease issues. Let's talk about some other kinds of toxicities we may see in practice. One is called ototoxicity. Ototoxicity is related to toxicity to the ear, and a subset of that could be drug-induced deafness that can happen. You can see tinnitus or ringing in the ears. You can hear hearing loss. Sometimes the manifestation is not hearing loss, but is more got to do with vestibular changes in vertigo or like for patients. The ototoxicity itself, the risk factors depend on the drug. There are a few drugs that are known to be ototoxic. The classic ones we worry about are some of the antibiotics, particularly the aminoglycoside antibiotics like gentamicin and tobramycin, but other drugs can do it as well. And when these drugs accumulate in the ear, they can cause either temporary or sometimes permanent accumulation in the ear, causing tinnitus or worse, hearing loss, permanent hearing loss. Here's a list of some other drugs that are common. Most of what we think about is some of the antibiotics or the nonsteroidals in high doses, particularly the salicylates. We also have drugs that can cause eye toxicity, ocular toxicity. We'll come back and talk about this later in the year as well. Sometimes they can cause pigment changes. They can cause swelling around the eye or the eyelid. They can affect the muscle tone in the eyelid, or they could affect other types of muscle movements, something called nystagmus, which is like a twitching of the eye, particularly when folks look to the left or to the right, or ocular gyrocrisis, where their eyes look like they're rolling back in their head. There are many medicines that cause folks to have reduced tears, particularly the antimuscarinics can do that. Sedatives sometimes can do that as well. Some drugs have the opposite effect and produce a lot of tears associated with them, particularly the cholinergic drugs. And some drugs contribute to conjunctivitis or inflammation of the cornea. That's particularly true for drugs that we instill in the eye that could be irritating. But that can happen with systemically administered drugs as well, including, for example, some chemotherapeutic agents. We also can have corneal deposits of drugs with high doses usually, and that's seen with some of the older phenothiazine antipsychotic drugs. There can be lens changes, opacities, again, with the older antipsychotics. You can have pinpoint pupils or dilated pupils as well, so that becomes an issue. Sometimes it's used diagnostically to determine what drug exposure people have had. You can also have retinopathies, probably one of the most important of the adverse effects, because that can be potentially permanently impairing vision. And so there are some drugs, for example, we're very careful about how we use those drugs, and we are worried about retinopathies or optic nerve damage associated with them. Optic nerve damage, the one I think of that we worry probably as much about with optic nerve damage is ethambutol. It's an agent we use for treating tuberculosis. But with some of these other meds as well, it becomes important that the ophthalmologist evaluate patients on a regular basis for these riskier drugs for significant optic nerve damage risk and evaluate whether or not it's safe to continue that therapy or not. A number of drugs also are associated with sexual dysfunction. We'll talk more about that later in the year, but this is the ability of a patient to either have an orgasm or have a man to have an erection or interest in or pleasure in sex. And what's sometimes difficult is that patients, particularly patients of an older generation, may be embarrassed to have that conversation with the healthcare providers. And so important to be able to be in a position where you can be develop a rapport with the patient to make it a safe environment for them to talk about such things. The types of sexual dysfunction are sort of listed here. We'll talk more about those later in the year. But we think of sexual desire disorders, sexual arousal disorders, or ability to have an orgasm, pain disorders associated with sex, or other factors that affect sexual dysfunction, particularly depression or trauma or a post-surgical event that affects somehow sexual function in some way, shape, or form. A male erectile dysfunction, pretty common, and there are lots of etiologies for that, particularly vascular, particularly in diabetics, for example, who have vascular changes. Antipsychotic drugs are associated with sexual dysfunction. Antidepressants are very common to do this. It's quite common that at least decreased libido or interest in sex is seen with a lot of the antidepressants. There's a couple of exceptions to that rule, but most antidepressants are associated with that. Other drugs that are central nervous system drugs can have some effects on sexual function as well. Hypertensive agents, the older ones in particular, including the beta blockers, are notorious for causing sexual dysfunction. The agents that are most commonly used as first-line therapies now are much less likely to cause sexual dysfunction. And there are a host of other drugs that can cause sexual dysfunction as well. There are also drugs that can have an effect on fertility. For men, drugs that impair sperm production. For women, also can affect fertility, particularly estrogens and progestins, as you'd well imagine, because we use those very agents for hormonal contraception. All right, the next block we're going to talk about, which sort of wraps things up in this section, are drug hypersensitivities. As we discussed earlier, a small percentage of the bad things that can happen to patients around drug therapy are allergic reactions. It's important for us to be able to recognize and document these because the outcomes can sometimes be fatal. So important for us to recognize that. But these allergic reactions take different manifestations, and they often happen after the second or subsequent dose of a drug, after the patient has initial exposure to the drug, whether or not we're aware of what that exposure is. Classically, the adverse reaction caused by immunologic mechanisms or drug hypersensitivity can happen within the second dose early on, or it can happen months or years later, and can present with a rash, can present with angioedema, breathing difficulty, asthma, full-blown anaphylaxis. There can be less severe presentations as well based on the type. And the classic way that you would diagnose a drug hypersensitivity, although ethically it might be impossible to do this, would be to, does the hypersensitivity go away when you de-challenge the drug, when you stop it? And does it reoccur when you re-challenge the drug? Now, someone with a full-blown anaphylactic reaction, nobody is going to want to re-challenge them to that drug unless there was a way we could mitigate that negative outcome and there was an overwhelming need to use that drug. The only example I can classically think of here is someone who has a serious infection for which penicillin is the only choice. For example, syphilis, tertiary syphilis. for someone who has an anaphylactic reaction to penicillin. And in that case, we would look at using a desensitization protocol, which we'll talk about more later in the year, as well as making sure we had all of the treatments available for treating anaphylaxis right on board. So things that predispose patients to hypersensitive reactions in part include age, genetics, concurrent diseases, prior drug exposures is a big one. And then there are other factors. For example, if the patient has had frequent or intermittent exposures to that drug, is it a sensitizing agent itself? The drug itself, is it sensitizing? And what was the route of administration of that drug? There's also this concept of cross-reactivity, that if someone has a full allergic reaction to one chemical compound, is it a portion of that chemical compound that triggers the allergic reaction? It may not be the whole molecule. It may be just, for example, with beta-lactams, is it the beta-lactam ring, which is found on both penicillins but also cephalosporins, or is it something other, some other molecular component of it that's not the beta-lactam ring? And so cross-reactivity reflects the concept that one drug can trigger an allergic reaction that has happened from in a patient who has never taken that drug, but has taken a chemically similar drug with it. Allergic reactions are typically initiated by either the drug itself or very often not the full drug, but a portion of the drug or a metabolite of the drug. So it's really important that we always get a good allergy history before we give medicines. In most electronic medical record systems, it's impossible. We've set stop gaps intentionally in electronic medical record systems that if you don't have an allergy history in for that patient, you cannot order medication. And so that's pretty common. It's that important that we really do know what the patient's allergy status is. Keep in mind that many of the allergies, we're going to talk about four main classes of hypersensitive reactions, involve the immunoglobulins. You remember immunoglobulins probably from biochem. They are large glycoprotein molecules produced by plasma cells in response to antigenic stimulation. And there are 5 immunoglobulins: IgG, IgM, IgA, IgE, and IgD. IgG accounts for almost 3/4 of the antibodies that are in the serum. They're found in blood, they're found in lymph, and in cerebrospinal fluid. They're found in other areas of the body as well. And they're the major antibody involved in secondary immune responses. They cross the placenta. They provide temporary immunity to newborns because of that ability to cross placenta. We consider that passive immunity. IgM accounts for between 5 and 10% of normal of antibodies in the normal serum, and these actually work to trigger IgG production in acute infections. That's really their role. IgA are kind of the first defense. They're the antibodies that are found in higher levels in secretions, particularly in tears and saliva in the stomach, and they really serve as the first immune response, particularly protecting, for example, food ingestion or other exposures in the body. IgE has, luckily, it's a fairly, in minute quantities compared to the other immune globulins. They're found in tissues and surface membranes, but IgE is what is responsible for the very severe anaphylactic and severe hypersensitivity reactions. So if you have an allergic reaction that is IgE mediated, we are really concerned about full-blown anaphylaxis in that patient. So you want to be aware of that. Finally, IgD function is a little less clear, also not found to a great extent. We're going to classify drug allergies in 4 groups. You may have heard this in other courses you've taken as prerequisites for coming into the PA program. I'm not sure. But most students that I've worked with over the last couple of decades have heard of these things before. Type 1 hypersensitive reactions are anaphylactic reactions in nature. They're the most severe. Type 2 cytotoxic reactions, Type 3 are serum sickness kind of reactions, and type 4 are delayed types reactions. There's a pictorial here, a graphic, at least a table that kind of explains these. Type 1, classic anaphylaxis or precursors to anaphylaxis, urticaria, angioedema, bronchospasm. Type 2 and type 3 include vasculitis and serum sickness. And type 4, really contact sensitivity. Think of type 4 hypersensitivity as something more like poison ivy, for example. So type 1 occurs soon after exposure, really usually the second exposure to the drug, but you may not know the first exposure. For example, patients who have a full-blown anaphylactic reaction to penicillins, their reaction may be the first time they ever took a dose of penicillin, but maybe their prior exposure to penicillin was related to antibiotics used in meat products or in animal feeds or something. So they really had an exposure to penicillin before. It's just that we don't necessarily know what that exposure was. Typically, anaphylactic reactions, they will involve IgE that attach to mast cells, and then when the mast cell becomes activated and degranulates, it releases all these chemical substances that produce or the risk for anaphylaxis. Very commonly, this initial type of reaction may not be a full-blown anaphylaxis, but it may present as hives, urticaria with severe itching. And if we see that type of immediate reaction happening, then we are worried about the next exposure to that drug could be potentially full-blown anaphylaxis. So you want to be aware of that as a possibility. Type 1 reactions, the most sensitizing I think of typically are penicillins. Those are the classic ones we worry about for the most part, but there are others as well. So here's what happens with anaphylaxis, really, or anaphylactoid type of reactions. IgE attaches to the mast cell after the first exposure. That IgE is specific for, let's say, penicillin or whatever the exposure is. On the next exposure, that antigen, be it penicillin, whatever, attaches to the IgE that's already on the mast cell, and then the mast cell degranulates. It opens up and releases all of these chemical mediators that result in either urticaria and or angioedema and or full-blown anaphylaxis. They involve histamine, leukotrienes, other chemical mediators. Let's look at some of those chemical mediators. Histamine is one that is responsible for vasodilation. There's eosinophilic chemotactic factor, neutrophilic chemotactic factor, and other factors as well that are sort of listed here. Let's now look through some of those specific functions of each of those sets of mediators. We have some newly generated mediators that happen include the leukotrienes, the prostaglandins, the thromboxanes, as well as platelet aggregating factor, some of the major ones that you will see here. So as it relates to mast cell mediators and what they do, bronchospasm is triggered by histamine, by leukotrienes, by prostaglandins, thromboxanes, and platelet aggregating factor. So if someone has a bronchospastic airway disease, we could give them an antihistamine, but an antihistamine is only going to address part of the problem. It won't address all the other mediators associated with bronchospasm. So much better for us to avoid the allergy in the first place. If we're managing it, we are going to give Benadryl or diphenhydramine as the NH1 histamine 1 blocker. That will help, but it won't necessarily get to all the other factors that are also involved in bronchospasm. So we're also going to manage that in part with epinephrine and perhaps inhaled beta-2 agonists. So important to keep that in mind, but much better to avoid the problem in the first place. You can also get mucosal edema. Mucosal edema also triggered by some of these very same mediators. You can get excessive mucus secretion. Again, some of the same mediators involved there. And airway inflammation, some different and some of the same mediators also. All of these contribute to the full-blown or variants of full-blown anaphylactic reactions. When someone presents with anaphylaxis, they can present with some or all of these symptoms. Classically, we think of airway edema and obstruction in conjunction with very low blood pressure or shock. You could have bronchoconstriction associated with that airway obstruction, and many times it's accompanied by nausea and vomiting. Here's a pictorial of that. The classics for the presentation might start with an itchy or runny nose and very quickly moves toward some of these other issues. You could have skin hives and itching. You can have swelling in the perioral area. You could have pelvic pain. You can have loss of consciousness, all of those respiratory symptoms, as well as diarrhea, vomiting, crampy abdominal pain, and even loss of bladder control. That's anaphylaxis, type 1. Now I'll move on to type 2 cytotoxic reactions. Refer to a process pertaining to how these reactions happen. It's a little more delayed, and the mediators are a little bit different. But we'll see this with certain types of hemolytic anemias. We'll see this with drug-induced systemic lupus erythematosus. We'll see this with quinine, procainamide, hydralazine. And the mechanism here, this hemolysis, for example, is very similar to the hemolytic anemias we alluded to earlier on. Here's a pictorial graphic of how that might present. They could be autoimmune in their nature. We'll see sometimes it happens abruptly after the patient's been taking the drug for many years. We can see an increased eosinophil sedimentation rate. You can have a positive ANA, which is an anti-nuclear antibody test, which is significant for some of these autoimmune systemic lupus type of responses with or without anemias. Type 3 reactions are referred to as serum sickness reactions, and they, in some ways, are like type 2 reactions. They can involve complexes being deposited, antibody complexes being deposited in the skin, in the joint, in the lymph nodes, can be associated with fever. There's a fair number of drugs that are associated with this, including rarely but happening the penicillins and the sulfonamide antibiotics. Here's a graphic of what those deposits look like. These complex or immune complexes deposited in tissue, they can cause vasculitis, they can cause other sort of irritation to localized tissue. Serum sickness, typically this type 3 onset is within a couple of weeks of exposure, and it can be caused by a number of drugs, but it's fairly rare to actually see this in practice. Finally, the type 4 reactions, which are more common. Probably type 4 is as common as any of these types of reactions. They're a classic contact dermatitis, and it's uncomfortable for a patient, but not nearly as severe as type 1 hypersensitivity is. Type 4 typically requires a few days to be evident, usually 48, 72 hours after exposure. And the classic things we think about, classic examples are either poison ivy or tuberculin testing, skin testing, tuberculin testing. But we can also see it with sunscreens, with acne preparations, with topical creams and ointments. The reaction typically is that a foreign body or the drug itself enters the body, attaches to a macrophage, which then triggers a presentation to a T lymphocyte. The T lymphocyte then gets deposited in tissue and results in the inflammatory reaction we see, typically usually 48 or plus hours afterwards. The classic example of type 4 reactions for drug therapy is a rash that happens with amoxicillin or ampicillin a couple of days to 3 or 4 days after we start therapy. So a rash with an antibiotic like penicillin or ampicillin, if it happens right away, we give the drug and within minutes you see this rash, you see other hives, severe itching right away. That's likely IgE mediated and likely a type 1 hypersensitivity. That's big news. That's a big worry. If folks' history presents with a 3 or 4 day delay in a rash, and it's maybe a petechial rash that's covering the whole body or part of the body, that's clearly we want to avoid the drug. But if we absolutely had to use a penicillin again, it's probably safe to use something different than amoxicillin, and if something bad happens, it's uncomfortable, but it's not necessarily life-threatening. So important to be able to differentiate that. The nature of allergies then can be generalized or they can be organ-specific, these hypersensitivity reactions, and we also talked a bit about pseudo-allergic reactions earlier on. So all of these are variables to think about. Important when you try to determine with a patient what their allergy history is, that you spend enough time to get as much good information as you can as that gets documented in the record. So you want to be clear, what happened, when did it happen? Was there a time course that explains that this, in fact, was a drug-induced reaction or not? What's the severity? And then document in the medical record not only that there's an allergy or an intolerance or a hypersensitivity, but also what happened and how it happened, which will help you in the future, but any other healthcare provider in the future, to weigh the risk and the benefit of using that therapy or a variant of that therapy with that patient if they should need it in the future. Adverse reactions, again, happen to a lot of patients, so we need to keep in mind that they can be serious or they may not be quite so serious. Just keep all of this in mind as you're weighing the risk and the benefit of therapy. You ought to have a good indication for everything we're using and be very clear about its role when we're using it with patients. One of the ways that we can minimize adverse reactions is, first of all, not use as many drugs. And so if you can find alternatives to not use drugs, do that. But when an adverse reaction happens, it's important for us to be able to document that and also to share that with the manufacturer or with the FDA and to educate patients about what we do to manage that in their care. And then the last thing to do is when particularly a drug that's relatively new to the market or a type of reaction that isn't published in the medical literature very well that we see, we'll make a report to the Food and Drug Administration and their program called the MedWatch. And you can do this online via the FDA's website to make a report. And these reports are actually important as post-marketing reports as a drug is on the market to get a groundswell of information about whether a labeling change has to happen or whether there needs to be some concern or investigation into why these reactions are happening to a greater extent once the drug's on the market, and then reevaluate whether that drug has to get withdrawn from the market or some other action needs to take place.